And thank you for the invitation to speak. So there is going to be some overlap with what Bryn said, but I don't think that necessarily matters. And I'm going to focus on the use of exome sequencing for the diagnosis of fetal abnormalities. Just my disclosures, so I have had support from a number of commercial companies, and I also have funding from the NIHR and other sources for my research, but neither myself nor my family benefit directly from these collaborations. So as Bryn has told you, and I'm going to do a lumping job, so he might tell me off later, that standard testing in an structurally abnormal fetus, and I'm going to focus on the abnormal fetus because, as Bryn says, I don't think we have enough knowledge yet to go into using this technology in a normal appearing fetus. So rapid aneuploidy exclusion will explain about 30% of fetal abnormalities. Karyotyping will then detect about another 5% of large unbalanced rearrangements. And as Bryn's told you, microarray will then go and detect microdeletions, etc. But that will still leave about 60 to 70% of fetuses with a sonographic abnormality without a genetic diagnosis. And so I'm going to talk to you about how, when, and what the benefit is and what the pitfalls are for fetal exome sequencing. And sequencing actually has resolution down to the single base. It detects individual mutations, and so you can detect monogenic disorders. Just briefly to think about the different types of sequencing. So whole genome sequencing will sequence the whole of the genome. That includes the gene coding region and the bits in between which we don't know what they necessarily do. There'll be variable coverage even with whole genome sequencing depending on the platform you're using and the depth of your sequencing. Whole exome sequencing just sequences the exome, which represents less than 2% of the genetic code, but it contains about 85% of all known disease-causing variants. And then you can offer a clinical exome where you're just sequencing known genes. So, for example, at Great Ormond Street, we have what's called the Goshome, which has about 60,000 genes. So you'll just sequence those genes. Or you can have a targeted clinical exome whereby you may be doing whole exome sequencing, but actually restrict your analysis to a specific area of the genotype, of the genome, which reflects the phenotype that you're looking at. So, for example, I'm going to tell you about skeletal dysplasias later, and there are about 240 genes responsible for these conditions, and you can just target your analysis to that. So Bryn has given you the data and clearly shown you that exome sequencing can increase the diagnosis, and this is the data from the BEST review published in Prenatal Diagnosis earlier this year, where the detection rates varied from 6% to more than 80%, and it very much reflected the differences in the criteria, the interpretation, the reporting and other issues. And I'm going to go through some of those issues as we go through this talk. So it does increase the diagnosis, but I think we need to consider some of these other things, some of which Bryn has covered, and I'm going to go through one at a time. So what about the clinical utility? And I'm going to give you some examples here. So this is a case that we saw at 16 weeks gestation, slightly short bowed long bones. We thought it, and a normal looking thorax and mild hypermineralization. So we thought it might have osteogenesis imperfecta type 3. We did exome sequencing, again trio exome sequencing here for speed in order to inform the management of the pregnancy if necessary. And this showed this homozygous mutation in the LEPR1 gene, which is responsible for osteogenesis imperfecta type 8. So this is recessive. And here it aided the prenatal counselling and the prediction of outcome, although the parents had decided already to terminate the pregnancy. But we were able to tell them what the recurrence risk was and offer prenatal testing in a future pregnancy. This is quite an interesting one here. You can see that this fetus presented with a big nuchal translucency, and then at 20 weeks gestation we saw it had very swollen feet, and the nuchal had increased here. We did exome sequencing here and identified a maternally inherited Milroy syndrome gene. Now, Milroy syndrome is responsible for peripheral edema, and on close questioning, mum had said when she went home and talked to her mother about it, she'd had swollen feet at birth, and this explained the condition here. And this one, another one here, we see this baby presented at 25 weeks with clenched hands, talipes and micrognathia, and came in with a normal karyotype. So I thought maybe this was, and when Dad walked through the door, I saw he had a very, very small jaw. So I thought this might be a distal dominant arthrogryposis, but he had no evidence of any contractures, he had no history of any contractures, he just had a small jaw and no other problems. And this indeed was a paternally inherited mutation of Freeman-Sheldon. But again, this allowed us, in both cases, it allowed accurate prenatal counselling, it aided informal parental choice, and in both cases, these pregnancies were continued, and it also informed reproductive choices in the future. This is another one which presented at 14 weeks gestation, and you can see here, short, very angulated humerus, but all the long bones were very angulated, and we thought this might be OI or possibly hyperphosphatasia. Looking at the parents, mother was short, unusually short, but she had no evidence of a skeletal dysplasia apart from the short stature. She had a normal blood alkaline phosphatase, but she was pregnant, and that can distort your alkaline phosphatase levels. And she had a slightly increased urinary phosphoethanolamine. So again, we thought she might have hyperphosphatasia. And indeed, the sequencing here showed that she had this alkaline phosphatase mutation. So this was autosomal dominant alkaline hypophosphatasia, and this improves with pregnancy. So whilst it looks absolutely dreadful at 13, 14 weeks gestation, those long bones do shorten out over time. So it allowed us to give accurate counselling, it aided again in parental choice, and it reassured these parents, and they continued the pregnancy. And indeed, the baby was born with findings consistent of hyperphosphatasia and is doing well. So which groups, now Bryn has shown you some data here, which groups of fetuses might benefit most? Sequencing is expensive still, and we do need to have trio sequencing, which makes it even more expensive if we're going to inform pregnancy management. So this is the data that Bryn alluded to that we're doing in the UK. This is the PAGE study, the Prenatal Assessment of Genomes and Exomes. It's about to be published in The Lancet. And here, again, completely unselected, any fetus with any abnormality, including a nuchal translucency of greater than 4 millimetres, was eligible to be recruited into the study. No genetic review, no expert review. Most of them had a normal karyotype or array, and we did trio testing. And we focused our analysis of the whole exome to a fetal panel of genes which we thought would present prenatally. And the pathogenic changes were only reported after pregnancy. So we were only reporting results that explain the phenotype and after pregnancy. Recruitment was across the whole of the UK, but the results were reviewed at a national multidisciplinary meeting. So we had WebExes, including geneticists, fetal medicine specialists, and clinical scientists to interpret the results. And this is an overview of the interim results from 610 trios. And you can see, as with Bryn's data, if you have a multi-system abnormality, so abnormalities in more than one system, the detection rate was about 15.4%. If you go to single systems, and here, these are isolated single systems, so I'm not putting something with it had to be an isolated cardiac or isolated skeletal abnormality. You can see that there's quite a variation between the groups, although I think the numbers are still quite small. But quite a decent hit rate with, in skeletal and cardiac abnormalities, and lower in all the rest. And overall, our detection rate in the whole cohort was about 8.5%. And of note, we picked up about another 24 or 3.9% of variants of unknown significance, which actually may have potential clinical utility. So a pathogenic mutation in one of a recessive mutations, for example, that are genes that might be, if it were homozygous, might cause that phenotype. So how does our diagnostic rate compare with other studies? And this is the data that's shortly to be published from Ron Wapner and Bryn's group. And you can see that unselected, the numbers are roughly the same. It's around 10%-ish. Multiple anomalies, absolutely higher higher hit rates here of between 15 and 18%. And the isolated nuchal translucencies, we find about 3.2% of an isolated nuclear translucencies had an abnormality, but they are very difficult to interpret because you've only got the nuchal translucency. And I don't know whether Bryn would agree, but just doing exome sequencing on this cohort of babies at the moment, I think is challenging. If we go on to look at cases where you've got higher selection, you will see a much higher hit rate. And these are just 3 studies here. So a small study of brain anomalies with a 50% hit rate when it was actually selected by genetic or fetal maternal review. So it's not just anything, it's selected. Whereas you will see that in the Page study for brain anomalies, this included mild ventricular megaly, many cases of which resolve spontaneously. So this is when you really choose what you're going to do sequencing on. In skeletal anomalies, then I'm going to show you this data in a minute. We had an 87% hit rate, that's our current hit rate. And that's where you review it with clinical geneticists before you decide to do the exome sequencing. Whereas in the Page study, the hit rate's much lower, 15%, but that includes things like isolated talipes, isolated transverse limb defects, where you might not necessarily expect to see a genetic syndrome. And similarly, with the Baylor group have recently published some of their data, and they've got about a 39% hit rate when they review all of the cases with a genetic review first. So clearly, if we're going to be successful in pregnancy, or make this useful in pregnancy, we've got to deliver a result in a pretty short turnaround time. And we've demonstrated that this is possible. What we've done here is, it's okay on the screen here. These are cases with a query skeletal dysplasia that are referred to us. We then review them with a multidisciplinary team discussion. So we review the images with a fetal maternal medicine specialist who is expert in skeletal dysplasias, with the clinical geneticists and with the clinical scientists, and then select the cases that look as if they're going to have a monogenic disorder before going on to exome sequencing. I think this is really important, and I think multidisciplinary team working is going to become more and more part of our daily work, not just in fetal medicine, but in everything really. And then we go ahead and do the sequencing. We interpret the sequencing results using a targeted panel of 240 skeletal genes. And we are getting our results. Now it's in around 10 days, the results are coming through. And again, once we get the sequencing results, we review the images, again, with the referring clinician and the geneticist, have a multidisciplinary team discussion. And those results, where we get a sequence result which explains the phenotype, we are validating and reporting back in pregnancy to inform management. And using that system, we have made 19 diagnoses in 22 cases, that's 86%, and time to diagnosis is now about 10 to 12 days. And several of these cases actually continued the pregnancy because the abnormality was less severe than might have otherwise been thought. You can see that we've identified 7 recessive cases, the majority are de novo, and 2 maternally inherited cases. One's that maternal case of hyperphosphatasia I described, and another of osteogenesis imperfecta type 4. So the other problem with exome sequencing, and indeed with many forms of whole genome sequencing, is that we do not get complete coverage of the genome, and therefore we can't necessarily rule out a genetic disorder. And this is a case here. So this case presented at 20 weeks with postaxial polydactyly, an AV canal defect, large bright kidneys, and hydrocephalus. Exome sequencing revealed a heterozygous mutation in the DYNC2H1 gene, which is responsible for ciliopathies, and parental sequencing at the time showed this was paternally inherited. However, these mutations are usually associated with recessive disorders, and we had an 87% coverage of the gene, and despite higher depth of sequencing, we could not identify the other mutation, the maternally inherited or de novo mutation. The parents, in view of the severity of the abnormalities, terminated the pregnancy and post-mortem confirmed the sonographic abnormalities and said it was suggestive of a ciliopathy. And we have they have been counselled a 1 in 4 recurrence risk. But at the moment, the only way we could do prenatal diagnosis early in pregnancy would be to exclude the paternal mutation. Now, what about incomplete phenotypes or new phenotypes? And I think this is very challenging, and Bryn again has alluded to this. So just let me give you a couple of examples. So these are from the PAGE study, and remember, we are only reporting phenotypes that results that explain the phenotype, and then we're reporting them after pregnancy. So the first case was one which presented with gross polyhydramnios. Now, to be honest with you, they're slightly outside the eligibility criteria, but it was really significant polyhydramnios, normal anatomy and normal growth. And this baby had a de novo mutation in this gene here, which is responsible for Bartter syndrome, or recognised as occurring in Bartter syndrome. We didn't report it as we only had isolated polyhydramnios, but the postnatal diagnosis was Bartter syndrome. So this is an example of a prenatal presentation of a condition which we recognise postnatally, but need to learn more about the prenatal phenotype. And here's another one. This baby presented antenatally with a small head and poor growth and was referred for exome sequencing. We had a de novo mutation in the NSD1 gene, which causes Weaver or Sotos syndrome, not reported because these are overgrowth syndromes, so you wouldn't expect necessarily to see it with a small head and poor growth prenatally. 1 year of age, the baby's head was more than the 95th percentile, and the baby had facial features of Sotos syndrome. So again, and since we found this case, I've identified another similar report in the literature of poor growth antenatally that subsequently been recognised as Sotos syndrome postnatally. So here we are, recognising genes that we know with new phenotypes prenatally. The other thing is that ultrasound really, or whatever imaging we do prenatally, offers us a limited phenotyping. It doesn't allow for detailed dysmorphology. It's getting better, but it's not that detailed. So it's an incomplete clinical examination. We can't assess the developmental development, so that again is a limitation on our phenotyping. And again, in the timescale of pregnancy, there's often a limitation of other laboratory tests. So as I've just shown you, we can identify new phenotypes of known conditions. And then there's the lethal prenatal phenotypes, which are not really well known postnatally because they are lethal. And we haven't seen that many of them. And they're not represented in the current databases in the literature. So there's a lot of ifs and buts here that we need to resolve. And this is some examples from the PAGE study. Of the diagnoses that we made in PAGE, 11 were not previously reported prenatally, but they had sonographic features associated with their with these findings. So we are identifying new presentations of known genes here. And so I think that this sums up the fact that we really do need a better understanding of fetal phenotypes with systematic annotation and data sharing, and that probably needs to be on an international basis. And indeed, we in the UK are beginning to work now with Baylor and with the group in Columbia to try and do some of this. The other issue is and this is a seriously challenging issue, what are we going to report in the prenatal setting? Are we just going to report the pathogenic or likely pathogenic variants related to the phenotype or the indication for the whole exome sequencing? Or should we be reporting pathogenic and likely pathogenic variants of clinical importance but unrelated to the indication? So secondary findings like medically actionable information such as serious childhood diseases or late onset disorders. For example, predisposition to cancer, pharmacogenetic variants, etc., etc. And should we be reporting the variants of unknown significance in genes that are relevant to the indication, but not yet reported as pathogenic? What should we be doing there? Or should we indeed be reporting variants of unknown significance in significant genes that are not relevant to the indication? So there's a lot of questions here. Should we be applying the same principles prenatally as we apply postnatally? Or should we try and have a more focused report? And I think one of the ways we're getting around this in the UK is to do more focused interpretation and maybe use a targeted clinical exome, or at least if you do a whole exome, interpret the sequencing results on the basis of a targeted exome. Again, prenatal sequencing, what should we be reporting? The ACMG guidelines for secondary findings give you 59 genes when you're reporting sequencing postnatally that should be looked for and reported. But the guidelines, that ACMG guideline specifically states that this excludes fetal samples. So we have a way to go there as well. And the other thing about doing a prenatal sequencing, as both Bryn and I have tried to emphasise, is we need to do trio sequencing in order to expedite the results. But if you're doing that, you're sequencing the parents. So what should we show? We can find secondary findings in the fetus that might be present in the parents, or findings that are present in the parents but not in the fetus. But if we report late onset, if we follow the ACMG guidelines and report these findings in the parents, and if they're also present in the fetus and we know about it, we're removing that child's right to decline screening, for example. So what is actionable, when is it actionable, and what should we be reporting? I'm not giving you any answers, I'm just giving you lots of questions here, but they're all things I think we need to discuss. Reanalysis, Bryn has shown you an example of that case where reanalysis over time identifies, it shifts the variance of unknown significance to pathogenic or benign. This is data from Ron Montner's group where he's reanalyzed the microarray data. The same thing is happening with sequencing. So when should we reanalyze? Or should we reanalyze, or should we resequence? Because our sequencing technology is getting better. Maybe we should, and it's cost a lot of money to store the sequencing data, maybe we should just forget the storage and resequence. But when should we do it? Clearly, if a new pregnancy is planned, maybe we should be doing that then, but we need to make those decisions. And finally, and I think one of the most challenging things which is going to face us all is the detailed expert counselling is going to be required, and who's going to do it. So for these complex tests, we're going to need pre-test counselling, we're going to need parents to think about what we're offering and what might be detected or not detected, and make their decisions to either opt out into routine antenatal care or to go for sequencing. And then they will all need, whether it's a negative or a positive result, because of the complexities and the need for changing and the changing over time, changing the diagnosis over time, they will all need post-test counselling and follow-up. So, and to get informed consent, and in our group we're now doing quite a lot of work on this, it's a lengthy process and it's very complex. And this is just a few of the things that needs to address. And so you can see that patients need to have a realistic expectation. We need to discuss what we are going to report, what we're not going to report, the implications for other family members, discuss who the patient is here, and the need and the presence of evolving knowledge, so results may change over time. So this is a complex problem. And we've just started to do some work and interviewing health professionals and patients who've undergone exome sequencing prenatally in the UK. And these are the worries here, and that the worries from this is just the health professionals here, but the worries here expressed by people who are involved with these patients are, and I think it's summed up here, my main concern is that prenatal will be offered by health professionals who don't know what they're doing. Once they've told a patient, oh, have this test, it's going to test for everything, it's very hard to undo that. And you'll all have been in that situation where people come to you with preconceived ideas. So we have a huge educational battle ahead of us. We do need national or international guidelines on what to do with prenatal sequencing, and this is a start. This was the ISPD, SMFM and PQC statement on prenatal exome sequencing published in January of this year, where we are clear that we think that this should only be applied to fetuses with an abnormality, that the multidisciplinary team involvement is key, and that must be fetal medicine, genetic and laboratory sequencing expertise, with testing done in an accredited laboratory. We're clear that health professionals must have an in-depth understanding of what they're offering, and education is going to be a key challenge, and we must be expediting that. And we felt that reporting was best focused on pathogenic or likely pathogenic variants in genes relevant to the fetal phenotype. And the potential for any other reporting, like parental carrier status, for example, must be addressed in the pre-test counselling, and patients must be allowed to opt in or opt out of that, as must the limitations, including the changing classification and incomplete coverage. So a good half-hour conversation I would put to you there. Anyway, despite all those those questions I've raised, I do think that we are making progress in addressing the challenges of prenatal exome sequencing. I think we've shown clinical utility. We are beginning to see which groups will benefit most and how to select cases. We can deliver rapid results, and we can avoid the reporting of VUs and other difficulties in reporting by using a targeted approach, even if that for now limits our diagnostic ability. I don't think it'll limit that much really. And we have demonstrated very clearly the need for close collaboration and multidisciplinary team working. But as I've said, there are a number of challenges that remain. Despite all of that, and Bryn says, how we're going to implement this. Well, Bryn, we are going to implement this in the UK Public Health Service early next year. And I think this is going to be, we've just reconfigured our genetic services, and all of our genetic testing in the UK will be delivered through 7 genomic laboratory hubs, of which I am leading one of those hubs. And as part of that reconfiguration, whole genome sequencing will be implemented for a number of conditions, as will whole exome sequencing. And as far as fetuses go, fetal exome sequencing will be implemented for fetuses with multiple structural abnormalities as detected on ultrasound, where the multidisciplinary team review, which includes clinical genetics, considers a monogenic disorder likely. So we're being very focused at the moment. We will be using a whole exome sequencing, probably with interpretation focused on a clinical exome, or maybe a large panel, but I think we're going to be allowed to choose that. But we are going to be doing trio testing. So I hope that I'll be able to come back and tell you in a year or so's time how national implementation is going. It'll be challenging, but I think it's really quite exciting. So on that, I'd like to thank all the people that I work with and all the patients who've helped us with our work. And if you want to hear more about it, then I'd just like to do a little bit of advertising for ISPD. I'm allowed. Yuval says I can advertise. ISPD, International Society of Prenatal Diagnosis, is in Singapore next year, and you can hear more about this and NIPT and D and all the rest of it. Thank you very much for your attention.